through, I won't dwell too long on this, but the main indications for enucleation is really when we have a blind and painful eye. And probably the most common reasons for us would be an example like this. This is a glaucomatous eye, where we have reached the limit of the glaucoma management that we can do. The eye is blind, the dog's in pain, enucleation was recommended. And then the second most common would be sort of like the bottom and the top images here, which are corneal perforations that for one reason or another are not amenable to surgical repair. And that can be if we have a large corneal perforation like this, we may have a retinal detachment at the same time. And so in some instances, we say, look, enucleation is the best option. Neoplasia is another reason, and that can be where we have a large intraocular tumor that's causing uveitis, causing glaucoma, or it can be these cases, this feline diffuse iris melanoma. And these, as I'm sure you're aware, are really tricky, the decision making as to what we do and when, but that's a subject for a whole other talk. Irreparable trauma, another reason for enucleation, and I've put in brackets at the bottom enucleation as a diagnostic tool, and we'll come back to this because histopathology on an enucleated eye can be really, really helpful. Now, I'm not suggesting we use it as a diagnostic tool early in the course of any disease condition, but sometimes you've reached the limit. You know, the eye is blind, you're worried about what's going to happen to the other eye, you're worried about something else with the dog or cat, and sometimes it's just a good thought to have in the back of your mind. This is a little diagram that I've taken actually from a publication that Heidi did quite a while ago now. It's an in practice article. It's a really good one if you can find it online about ocular sampling. And this just puts enucleation in the context of, I guess, other eye removal surgeries. So the far image, you can see, if you kind of look for these blue dotted lines, in the image on the far left, this is an enucleation, and we're removing the eye, the globe, sticking as close to the wall of the globe as we can. We're removing the eyelid margin, the conjunctiva, and the third eyelid. The middle picture is what we would call an exenteration, and this is where we're actually trying to remove all of the soft tissue within the orbit. If you're doing a complete exenteration, you're actually also removing the orbital periosteum. And that is indicated where we have orbital neoplasia, maybe in some cases of severe infection. That's quite a rare procedure for us to perform. Actually, what we're trying to do really is stick as close to the wall of the globe and leave that soft tissue in the retrobulbar space behind. Then the last picture on the left is what's called an evisceration. Again, we don't really tend to do this. This is done maybe a lot more in the States, I think. There's some situations where you would actually choose to remove the contents of the inside of the eye, leaving the cornea and the sclera as a shell. And then you put an implant in to maintain the shape of the eye. Ophthalmologists in the UK don't tend to do this. I think there are real questions as to the suitability of certain cases, the risk factors of doing that, how much of a benefit there is to the animal, and personally I'm not really that comfortable with the ethics of this. But you may come across the term, so it's good to know what they mean. So with our enucleation, what are we trying to achieve? I mean, for the carers, they're expecting you to remove the eye, they want adequate pain relief, and they want hopefully an acceptable cosmetic appearance. But as a surgeon, we're thinking about all of these other things. We're trying to avoid and manage the potential intraoperative and postoperative complications. And I'll touch on these as I go through, but really we're thinking about hemorrhage. During the surgery, we can come across something called the oculocardiac reflex, which I'll explain a little bit more. There's this risk that terrifies us all in the back of our mind of, are we going to cause vision loss in the other eye? And then post-op, what about wound breakdown? What about infection? Retained conjunctival tissue and cyst formation. These are all things that keep us awake at night. So enucleation techniques, you've got two camps. Which one do you do? So transpalpebral is that one where you stitch the eyelids closed. You incise through the eyelid margin, and you basically dissect backwards and remove everything in one go. Versus the subconjunctival technique, this is you want those eyelids nice and open, and you're going to go in through the conjunctiva, remove the globe first, and then when you've done that, you're removing the third eyelid, you're removing the eyelid margin, and you're looking for any conjunctiva that you could have left behind. The reality is, which one you choose the majority of the time is down to your preference, and I would advise people to do what they feel most comfortable with in most circumstances. There's a couple of caveats to that. We don't tend to use the subconjunctival technique if you are concerned about corneal neoplasia or if you have a really severe infection on the ocular surface. Because when you go through the conjunctiva, you could be introducing those bacteria from the surface of the eye into the retrobulbar space and increasing the risk of an orbital infection afterwards. And so that's why a lot of people tend to say, okay, well, the transpalpebral method instead, I can use that in every circumstance. So maybe that's the one I choose. That was always my view when I worked in general practice. It's what I did for 5 years. I was quite happy with it. And then I learned to do the subconjunctival method, and actually now I much prefer it. The advantage of the subconjunctival method is that you have a much better view of the anatomy as you remove the eye. You can find the extraocular muscles. You can stick really close to the wall of the globe. So you're not removing a lot of unnecessary tissue along with the eye. We do see slightly less blood loss with a subconjunctival approach. Now that will always be patient and surgeon variation is always a big factor there, but I think there is less bleeding. And so I think it's a really nice technique. So I'm going to briefly touch on points from both options. So hopefully you can pick up and just have a think about, do you like the method that you usually use? Would you like to try something different? Or are you happy sticking with what you know? So the big thing, whatever technique you're using, the key thing to think throughout the surgery is that you need to avoid traction on the optic nerve. If you pull on the eye with one eye, you're going to pull on the optic nerve, and this can damage the optic chiasm in the middle, and then we get vision loss in the opposite eye. And this is a really big deal, especially in cats. Cats have a shorter optic nerve, so it's much higher risk. But it is, in theory, if you had a good tug on a dog, I think you could cause the same problem. The other reason to avoid too much traction on the optic nerve is this oculocardiac reflex. And this is where manipulation of the eye as you're doing the surgery or pulling on the optic nerve will cause a really profound bradycardia, and your nurse will probably suddenly go, oh God, something's wrong with the anesthetic, what do we do now? And this is mediated by the trigeminal nerve and leading to a vagal response. And basically, if that happens, the first thing to do is just stop for a second, stop manipulating, give it a second and see if this resolves. And then sometimes if it doesn't, we might think about giving intravenous atropine to try and reverse that bradycardia. But to be honest, more often than not, just stopping for a second is all that you need to do, and then just being a little bit more gentle going forwards. So I've taken some images from Slatter's Fundamentals of Veterinary Ophthalmology, and I'll talk you through. So the transpalpebral technique, you can suture up your eyelids however you see fit. I like to just do a continuous suture because it's quick, and then to grasp the end with some artery forceps. Some people will use Alice tissue forceps. Obviously, you're removing that part of the eyelid margin, so you don't need to worry too much about the level of tissue trauma. And then you're going to make your elliptical incision with a scalpel blade. The next thing you're going to do is blunt dissect down, and I like to use kind of small curved scissors. So these are called Stevens tenotomy scissors. So they're nice and curved, so they help you follow the shape of the eye. Most of what you're going to do is blunt dissection, but you need to remember that at either side here, you have the medial and lateral canthal ligaments, which anchor it in place, and they're really, really tough. So at that point, you do need to cut, okay? Some people like these enucleation scissors. I actually do quite like these. I think sometimes when you're getting down in the back and you can't see what's going on, it's having a big pair of scissors where you can blunt dissect, you know everything's the right shape. They're great, but they're not essential. And then this is the bit that gets a bit controversial. Once you have theoretically sectioned all of your extraocular muscles, you've blunt dissected all the way around, you can then choose whether or not to clamp the optic nerve head and then cut between the clamp and the back of the globe. And then you have this, all of the textbooks telling you to put a ligature on here. I never do this No one who taught me ever did this. My advice to you would be not to attempt to ligate the optic nerve. In trying to do that, that's the most likely time for you that you're going to pull on it and you're going to cause that traction and you're going to risk that vision loss in the other eye. Trying to get the access is always really difficult. You're fiddling around in the bottom there. And the reason it's not necessary, don't get too hung up on this, is that actually most of the blood supply to the eye doesn't follow along, just follow along the optic nerve. In a lot of primates, the main blood supply to the eye comes from the internal ophthalmic artery, which follows the optic nerve. But actually in dogs, a lot of that blood supply comes from the external ophthalmic artery, which branches into different sections. And the internal ophthalmic artery is actually quite small. So you shouldn't really need to ligate that in order to achieve good hemostasis. Some people will still choose to clamp it, but not tie a ligature. I personally do neither. I think what you want to do is try and blunt dissect away as much of the tissue as possible, so you can see that the globe is really quite movable within the orbit. And then when you're comfortable that you've released everything, just cut, get it out as quickly as possible, and take your swabs and just put pressure, okay? And normally once the eye is out, you can do pressure for a couple of minutes, I say up to 5 minutes, and in the vast majority of cases, that is enough. It's nice if you have cautery. I have to admit, I don't use cautery in most cases, but it's nice and reassuring to have it there. And there's probably the odd one where you go looking and you think, okay, I do want to use that. The other two things I've put here in brackets, I personally don't really use them, but Liastipt is one of these hemostatic collagen sponges that you can actually leave in the orbit. And in cases where you're really worried about, you're really worried you've got a problem, you can pack the Liastipt in there and just stop and wait and keep putting pressure and see if that helps. I also have worked with people in the past who've used tranexamic acid if they really, really need to for antifibrinolytic properties to try and help with that. But again, touch all the wood, that's not something I've had to do myself. I would put a note here. We sometimes will enucleate eyes and we don't really know what's going on. If they have any evidence of bleeding in the eye and you're not sure what's caused that, just remember to think that this dog or cat could have a clotting problem. And if you're not sure, delay your enucleation, do some clotting times. If you're in a lungworm, I don't think we're in a hugely lungworm area here, are we? But it's around. I think doing a lungworm snap test is never the wrong thing to do if you're in doubt. The other tip I would have in terms of bleeding is to be aware of this structure, which is the angularis oculi vein, or the angular vein of the eye. This is actually one of the really common reasons for dogs or cats to bleed at enucleation surgery. And this vein sits in the medial orbit, so it's just kind of at the medial canthus or just above. Now, particularly if you're doing a transpalpebral enucleation, you cut down there, you blunt dissect. It's really common to just cut that, and that's where you get a lot of bleeding from. And so I would always just advise to be a little bit careful when you're doing your blunt dissection around the medial canthus, and to try and stick not to the orbit, keep away from the orbital rim, and stick as close to the actual eyeball itself. And then hopefully you'll avoid this structure and avoid that kind of scary moment where all that blood comes pooling up towards you. Wound closure, I'm not going to say much about this because, to be perfectly honest with you, you could ask 20 ophthalmologists and they'll all tell you different suture material as to what they use. My preference is to close these in 3 layers. So my first is a continuous layer close to the orbital rim to close whatever deep tissue I have. I would then do a subcutaneous and an intradermal. I use all absorbable suture, Vicryl or monocryl 4.0. Some people like to use nylon skin sutures, and that's not wrong. I just think that often the carers for these animals, they're really, really upset and emotional. They've been through a lot, and actually, yes, we see them back for a post-op check, but when you then have to start wrestling with the Frenchie to try and remove skin sutures, nobody needs that. Nobody wants that. So I think intradermals are really nice for these guys. So subconjunctival enucleation is the other approach, and as I say, this is my personal preference. So when you do subconjunctival enucleation, you want to make your incision through the bulbar conjunctiva, the conjunctiva lining the surface of the eyeball. To make access more easy, you will do lateral canthotomy first. You'll just take your scissors and you will cut about 1 centimeter through the lateral canthus. I've got a couple of images which were from Christine Heinrich did this beautiful, I don't know if you guys remember, I don't know if BSAVA still do these companion how-to guides, but she did one years ago which was how to perform a subconjunctival enucleation. If you can find it, it's great. It's got really good pictures, and I've pulled some of her photos. So you can see in the picture, that's your lateral canthotomy. It's going about 1 centimeter back. And that gives you then really good access to make a little snip through your conjunctiva and start to blunt dissect underneath. Now, these images from Slatter show you going really, really close to the limbus, just here. But actually what you want to do is go 5 or 6 millimeters back, because if you blunt dissect here and make your incision here, this gives you a really nice tag to hold on to, so you can actually cling on to that while you continue to blunt dissect around. Again, by doing this, you're so close to the wall of the eye that actually, if you really want to, you can see all of those intraocular muscles and cut them one by one. Again, I wouldn't clamp or ligate the optic nerve here. You're doing this blind. Effectively, you dissect as much as you can, and then that last cut is blind. The thing that makes people worried about the subconjunctival enucleation is, okay, well, what happens next? I've removed the eye. I've still got to deal with the third eyelid and the lids and the conjunctiva. And actually, I don't like these images from Slatters, because what they show you is cutting out the third eyelid, cutting the eyelid margin off, and then stitching it up. It's really important that you try and remove the conjunctiva, because if you leave conjunctival tissue behind, there is a risk that you will get a cyst form later on. So these beautiful images from Christine Heinrich, again, what you're looking for is the shiny conjunctiva. And when I first did this, I kept thinking, how do I know what's conjunctiva and how do I know what's just other stuff? And it really helps. Sometimes I will just pick up the third eyelid, chop that out, chop the eyelid margin off, and then go along with a swab and look for this. You can see the edge here. This is shiny conjunctiva, and then this has a different texture to it. And so that's what you're looking for. And then close it up the same as a transpalpebral approach. So that's the surgery itself. Anesthetic considerations. So we talked already about whether or not you need to do clotting times, a lungworm snap test, and that's part of your pre-anesthetic assessment. Is there an increased risk of bleeding in your patient? We've talked about the ocular cardiac reflex. So analgesia. We would always give a methadone pre-med, so you definitely need an opioid in your pre-med for these guys. I think most of us would always do some form of regional analgesia and some sort of local anesthetic block, be that a retrobulbar block or a splash block, and I'll come on to that in the next slide. A systemic non-steroidal is then usually sufficient, and that's what I would continue post-operatively, but we can use paracetamol additionally or as an alternative if needs be. And then the other thing is just to think about how your patient's likely to recover, because some of these dogs, not many, but some can be quite dysphoric on recovery. It depends what your anesthetic's been like, how painful they've been beforehand. And what you don't want is your dog to wake up, blood pressure to go through the roof, throw themselves around, and then to have more risk of bleeding. And so occasionally, we will think about sedating dogs for recovery just to keep that nice and smooth. In terms of those local anesthetic blocks, so I do quite like a retrobulbar block, but actually you have to weigh that up with how comfortable you are doing it and what the risks are to the patient. And if you're doing retrobulbar blocks, you need to be aware the globe perforation, fine, you're going to take it out in these cases, so less of a worry. But there is a risk of IV injection. There's a risk of intrathecal injection, so injection into the optic nerve, and that could be catastrophic and you could lose the patient. So I personally think it's perfectly acceptable to use a splash block, and you can put that into the orbit. And then if I do that, sometimes I'll do a line block in the skin as well, just to give a little bit more analgesia along the wound. I would always use bupivacaine for this. It's not as quick onset as lidocaine, but I think it's kind of satisfactory, and it gives you that analgesia going into afternoon or the evening when hopefully your patient will go home. I have no problem sending these guys home the same day. Sometimes we'll hospitalise them if we feel that that's right. Post-op, you need a buster collar. You need to continue some form of analgesia at home. Normally for us that would be meloxicam for 5 to 7 days. So the question about antibiotics. In my view, these are not usually required. I do tend to give IV cefuroxime at the time of surgery in most cases, but post-operatively I would only use them if I was really particularly concerned about a patient that was at high risk for a post-op infection. I do not use them routinely. And then I think it's really important for us to remember that this for us is maybe not that big a deal of a surgery, but for that pet's carer, it really, really is. And I think it really helps to have a nurse or someone who can take the time to talk to them about the swelling and bruising, warn them that we still have a tear duct here, and so it's not uncommon for us to get a little bit of a nosebleed on the same side within sort of 24, 48 hours of surgery. It's really nice to kind of counsel the carers on what to expect before they have the dog home. I always warn people that they're going to look awful when they go home. If they don't look awful, winner, they're really happy. But I always just warn people that they're going to look like they've been in a boxing match, because I think seeing your pet looking like that is can be a real shock for some people, and it's really upsetting. Coming back to that point about enucleation as a diagnostic tool though, I would really urge you to do histopathology on as many enucleated globes as you can. It really helps you confirm the diagnosis. But also, if you don't know what exactly has caused this, often it's a glaucomatous eye. You know that you've kind of reached the limit of what you can do. You know there's not a lot of hope left. You know that you're making the right decision, but you don't necessarily know why the dog got glaucoma in the first place. And so many diseases in veterinary ophthalmology are bilateral, but they're not symmetrical. And so we can have one eye and then you think you've done the right thing, and then it can be 2 months, 6 months, 2 years later, we see a disease come in the other eye and we think, oh, well, what happened with the first one again? Does anybody know? The other thing we see a lot is eye problems related to systemic disease, and sometimes that can catch you out. And so it really is worth, if you can, sending the eye for histopathology. I think most ophthalmologists do use Cytopath, and that's because Emma Scurrell at Cytopath is a fantastic ocular pathologist. If it's really good wherever you send your samples, so make sure you include some sort of history. But if you're not using Cytopath, it probably is, well, even if you are using Cytopath, it's always worth having a conversation with your pathologist. Actually pick up the phone, particularly if you're not sure if you're looking at something weird. Emma is great. She's seen basically everything eye-related, and so she knows exactly what to look for and will give you a really great report and will really help you. Will give a lot of advice. If you're using another lab, fine, but it's worth just picking up the phone and say, I don't know what's going on, or I think maybe this is happening. Are you happy looking at this? Is this something you're comfortable interpreting? So a lot of pathologists don't like eyes. Or if there's something that you think, oh, I think maybe this is going on, maybe telling them that can really make a difference in what they look for. Kind of my last point really is that sometimes we have dogs that need bilateral enucleation, and I think at that point it's really common to end up in a conversation about quality of life, because a lot of people really worry about how their dog is going to cope with no eyes, what it's going to look like, how people are going to react to it. And I've just put this in because I would really urge you not to rush into euthanizing animals because they're otherwise looking at having the second eye or both eyes removed. It's obviously a conversation to have. It's an individual decision. This study was published in 2019, and actually it was a questionnaire survey of kind of carer perceptions for dogs that had bilateral enucleations. 90% of them were really satisfied with the outcome and would do it again. Most dogs can adapt really, really well to this, and so it's a difficult one. There will be some dogs that won't cope. I would never tell someone that euthanasia is completely the wrong thing to do, but I would really try to discourage it or take the time to have that conversation, because actually some of these dogs do really, really well.